we will get started. A 39-week client reports her water broke 12 hours ago. Her temperature is 100.8, heart rate's 110, fetal heart rate's 175. What is the primary concern? All right. So for her, the answer is chorioamnionitis. Why do you think that now that we see that that's the answer, why do we think that's what the answer was?
The elevated fever could be a sign of infection, and it's a bacterial infection of the fetal membranes and the amniotic fluid.
Okay, good. Yep. So the elevated temp. What else about the scenario could point to the possibility of her having that bacterial infection of the amniotic membranes and the amniotic fluid?
Is
The
it
water
the fetal
breaking
heart rate?
12 hours ago.
The water's been broken for a while. And then Maddie, what did you say?
Is the fetal heart rate high?
What's a normal fetal heart rate?
Oh yeah, 110 to 160.
Yep. So we have fetal tachycardia. Yep, it is high. Is there anything else? What do we think of her heart rate?
Yeah, her mom's heart rate's elevated.
Mom's heart rate's also elevated. And so these three things are super diagnostic of chorioamnionitis: fever, maternal and fetal tachycardia. So when we say tachycardia in class, they say who's tachycardic, whose heart rate is high, and the answer is both of them. Okay. For this patient, what other things might we assess with her if she has chorioamnionitis besides fever and tachycardia for her and her baby?
Tender uterus.
Hmm.
Yeah, tender uterus. And any kind of like foul smelling or purulent amniotic
Good.
fluid.
Yeah, perfect. Exactly. Good. A client's receiving oxytocin to augment her labor. Which assessment findings should cause the nurse to immediately discontinue the oxytocin infusion? Good. So why would you guys want to discontinue oxytocin with late decelerations?
Is it because baby's in distress?
Well, yes, right? Late decelerations are bad. Okay. What's happening with late deceleration?
Uteroplacenta insufficiency.
Hmm. Yep.
Decreased
And
placenta perfusion.
good. Yes. So those are both correct answers. We have uteroplacental insufficiency, so we're getting decreased perfusion to the placenta. And so when we think about the things that cause late decelerations and uteroplacental insufficiency, we're thinking about her blood pressure. We're thinking about her position, like if she's supine, right? And then we're thinking about contractions, because if they're too strong, lasting too long, too close together, tachysystole, we're not giving time for the perfusion to happen. And so then the baby's not getting oxygenated, and we're seeing those late decelerations. So turning off the oxytocin is a good choice. What else, if we were seeing late decelerations, what would be even something to do before we even turned off the oxytocin?
Is it
Oh,
reposition, mom?
Reposition them all.
Reposition the mom. Good first thing to do.
oh,
Reposition
I
the
thought we'd
mom.
already said that.
Well, in this it didn't say. It just said when are we going to know to turn off the pit, which this would be the time to turn it off. What if instead she was having early decelerations? Would we turn off the oxytocin for that?
No,
What's happening with early decelerations?
they're at the same time as the contraction. That's what we want.
They're normal.
It's normal. It's at the same time as the contraction. And what is happening if we're seeing early decelerations?
Head compression?
Head compression. So probably progressing in labor, the baby's getting pressure on the head as it's coming down. So we wouldn't turn off the oxytocin for that. It's exactly what we want. So for early decels, that's something where it's normal, right? So we would document the finding, reassure the parents, stuff like that. But for late decelerations, we need an intervention. So reposition the mom, and then she's on oxytocin, we would turn it off. The nurse knows to frequently assess the following to identify magnesium toxicity. Okay, let's talk about this one some more. So who's at risk of developing magnesium toxicity?
Mom,
The mom. And any mom who's on magnesium could develop toxicity. Why would we be giving magnesium?
is it for prevention of seizures?
Correct. Prevention of seizures with what condition?
Preeclampsia.
Eclampsia?
So we're preventing eclampsia, and so she's preeclamptic, and we're using it to prevent her from having the seizures, which would be eclampsia. Okay. There is another time we use magnesium, and we use it, and with that mom's, the other mom is also at risk of developing toxicity, and this is something we're learning about in class this week. So you may not have learned about it yet. Do you guys know who else gets magnesium besides the mom who's preeclamptic?
Is that someone with HELP syndrome, or is that kind of on the same lines?
So HELP syndrome is the same line. Okay, so
Okay.
HELP syndrome, no, that's great actually. So HELP syndrome is a variation of preeclampsia. So your HELP syndrome patient is preeclamptic and they are still going to get magnesium sulfate. They just have the variation of preeclampsia that they have has a lot more significant involvement with platelets and liver involvement and poor perfusion to their baby over long term. Those babies are really tiny. There's a lot of things that happen with HELP syndrome too, but that patient's also on magnesium sulfate. But I'm thinking of something else. The other mom that could get magnesium sulfate besides your preeclamptic mom is going to be your preterm labor patient. So magnesium sulfate has a side effect of it's a tocolytic. It relaxes the uterus. And so we give it to moms that are at risk of delivering before 30 weeks. I think it's 30 weeks. It might be 32. Anyway, it is going to hopefully slow contractions down to give us time to give betamethasone and help mature the lungs. It's probably not going to stop labor, but it can help slow us down and buy time. And it has another effect for your baby if it's born preterm in that it provides neural protection. It helps protect the baby's brain because those little tiny fragile vessels are so small and can break and bleed easily. You can have brain bleeds and stuff. And so magnesium helps protect the baby's brain. So the other mom that could be on magnesium that could be at risk for toxicity is your preterm labor patient. Okay. So, but we mostly talk about it in relation to preeclampsia. So when we look at the best answer for this question, we're thinking about toxicity and so deep tendon reflexes, what might happen to our deep tendon reflexes if we're concerned that her magnesium level's too high?
They would be non-existent, right?
They would be, yeah, they would be going away. Okay, so absent deep tendon reflexes, definitely a bad sign. Respiratory status,
It's
okay,
gonna be decreasing.
decreasing. So respiratory depression is a huge concern. All right. Um, level of consciousness. So magnesium sulfate's a CNS depressant, so it's going to calm everything down. So level of consciousness, if they are becoming somnolent or unresponsive, that'd be bad. Also, urinary output is a factor. Okay. How much urinary output do we want?
30
30
milliliters
mLs.
per hour.
At least 30 mLs per hour. And here's the thing, guys, is that if she's putting out less than 30 mLs per hour, her body's not metabolizing through the magnesium properly. So she's not excreting it at the normal rate and she's holding on to too much, which then potentiates the toxicity and makes it worse. So very important that we're watching urinary output. So all of these are things that we're concerned about. Now, for those that picked blue, respiratory status is on here. Uterine tone matters in the way that since it's a tocolytic, after she delivers and she's on magnesium sulfate for that 24 hours after the baby's born, it could affect the uterine tone and increase her risk of hemorrhage, but it's not a sign of toxicity. That's just a side effect of the medication. Um, and deep tendon reflexes is concerning. Deep tendon reflexes in number one, deep tendon reflexes and level of consciousness are here. Clonus is here. If we have clonus or we don't have clonus, does that indicate toxicity for us? Does everybody know what clonus is?
Bonus is the beats of the feet, correct?
So clonus is a sign of hyperreflexia. And so with this, we flex the foot up, and when we let it go, the number of times that the foot jumps is the number of beats of clonus that you have. If you have clonus, she's hyperreflexive. If she doesn't have clonus, that just means our medication is being effective. It doesn't mean she's toxic. Okay, so losing deep tendon reflexes is concerning. Losing clonus is not concerning. Okay, which is why green was still the best choice here. All right. Which statement should alert the nurse of the worsening of gestational hypertension? Awesome. This is great. You guys all selected vision. So headache went away with Tylenol, normal pregnancy stuff. Heartburn after I ate spicy food, normal pregnancy stuff. Swelling in my hands and ankles that has gone down is also normal pregnancy stuff. But visual changes is concerning. Blurry vision, um, spots before your eyes, things like that, is concerning. All right. What other signs would be concerning with preeclampsia?
A headache that isn't curable.
Good. Yeah. So the headache with that Tylenol helped is fine, but if she has a headache that's not resolving, that's concerning. What else?
Positive clonus.
Yeah, well, yeah, positive clonus for sure. Another one that we can see with this is epigastric pain. So this heartburn when I ate spicy food is normal. But if they're having epigastric pain, that could be liver involvement. They're just feeling it more towards the front. And so epigastric pain could be concerning. It just kind of depends on the whole big picture. Since we know she has gestational hypertension, if she's got changes in her vision or blurry or difficulty focusing or whatever, if she's got epigastric pain, if she's got a headache that's not resolving, we would like to evaluate her. What would we do you think, to determine if her gestational hypertension has actually become preeclampsia?
Besides just like how she looks, her signs and symptoms.
Mm-hmm.
Could it be the creatinine levels
Okay.
and
What
urine
other labs?
output?
Okay.
Do you take, is it however many times the blood pressure is taken?
Oh yeah,
Okay,
the
so
blood.
blood pressure, yes, typically true. So it depends on how she presents. If this patient has gestational hypertension, which means they already have had elevated blood pressures more than 4 hours apart, and she didn't meet criteria for preeclampsia because she didn't have any other symptoms, which typically one of the big ones is protein in the urine, right? So her labs have been normal, her signs and symptoms have been normal, she's just hypertensive, and she wasn't hypertensive before 20 weeks. So this is a gestational condition. If you had a patient that came into your clinic and said, my vision's been, for the past 2 days has been really blurry, and we don't already have a diagnosis of gestational hypertension, the first thing I'd want to do for her is take her blood pressure, right? But on this particular patient, I already know she's hypertensive. We can reevaluate her blood pressure to see if her blood pressure is worsening and becoming into that severe range. Does anybody know the difference between hypertension and severe hypertension for our numbers?
Severe is gonna be like 160 over 110, and then
Yeah.
just like I guess that normal hypertension range is gonna be like 140 over 90.
Yeah, good. So we could definitely evaluate that. But this patient that I already know is hypertensive and is now having symptoms, we'd probably run our labs. Okay. We'd look for protein in the urine. We can look at the protein creatinine ratio. We can look at, what else would we look at for labs besides urine, protein in our urine? Liver function test. So
You said
AST and
fast
ALT.
In a urine.
And thrombocytopenia. We would look at her platelets. Okay, good. So the combination of her symptoms and her gestational hypertension is probably going to be enough to give her that preeclampsia diagnosis, but needing to check the labs and looking for those other things. All right. Client understands their insulin needs in the second half of pregnancy if they state they may require what? Okay, good. Increasing insulin. Okay. Your patient so first of all, any patient that's pregnant, their body tries to hang on to glucose. Okay. Um, and so for your diabetic patient, the more and more insulin resistant they become, the more insulin that they need. And so usually in the second, third trimester, those needs are increasing a lot. For your patient that has diabetes, what kind of teaching are we going to give? How is she going to know how much insulin she needs?
Blood glucose monitoring.
Right, good. So we need to have her doing that every day, checking her glucose levels every day, and so that and then they can adjust her insulin as those needs are increasing. Okay. Um, and this is really going to be important because if she's not managing her glucose levels well, what can happen?
Hypoglycemia.
Preterm labor?
She could have preterm labor. Maddie, what did you say?
Hypoglycemic or
Okay.
hyperglycemia.
Yep. And
Can
if,
she have a
Macrosomal.
macrosomic baby?
yeah. And so that's kind of going to be part of the big focus here. Okay, so there's a couple things early in pregnancy and even before pregnancy, if she's diabetic, she should have good glucose control, because early in pregnancy, if she has poor glycemic control, that's where we can see like the diabetes associated birth defects and stuff like that. Later in pregnancy, it's important to maintain that strict glycemic control, because it's the ups and downs and the peaks and troughs that drive macrosomia. And if our baby's macrosomic, is it going to fit through the vagina? Don't know. She might need a C-section.
No.
Yeah. And that actually can also increase her risk. Like if she has a macrosomic baby, that increases her risk of having like a shoulder dystocia too, if the baby's big and we try to deliver vaginally. So she might need a C-section, or it might also put her at risk of a shoulder dystocia if the baby's too big. So there's a lot of considerations with that strict glycemic control. And so doing daily glucose checks is going to help know as her insulin needs are increasing, so it's well managed. Okay. What else for our daily diabetic management besides doing our glucose checks, do you think?
Monitoring like carb intake.
Yep. So diet. So teaching her good. She
Okay.
still needs to eat carbs. She's growing up,
Ex-
but healthy carbs and diet.
Exercise.
Exercise, good.
If she's halfway through the pregnancy, do we want her monitoring her kid counts?
Sure. Yeah. Daily kid counts is a great way to just know how our baby's doing. The best way to really check our fetal status is going to be with a non-stress test. But if every day, if she's just monitoring kid counts, that's a really good sign that the baby's doing okay, because wiggly babies are happy babies. They're well oxygenated babies. Babies that are not well oxygenated aren't moving around a lot. And so if she notices that she's got decreased or absent fetal movement, then that would prompt her to be seen. So that's also a good thing to do. Yep, good job. I think ultrasound's the other one, is that they also watch the fluid level and the growth on ultrasound. That's the other one I didn't think to mention, but that's another tool. The nurse is caring for a client who has a placenta previa. Which of the following findings should the nurse expect? Yep, good. Painless vaginal bleeding, right? If we didn't know she had a known placenta previa and she came in with painless vaginal bleeding, what might we do to evaluate her?
Ultrasound.
On ultrasound. What's happening with a placenta previa that we could see on ultrasound?
The placenta is like kind of covering the opening of the cervix.
Mhm. So what kind of delivery will she have?
C-section.
Definitely C-section. And is this patient, wait, what was I going to say? Oh, is there anything very specific that would be contraindicated for her?
Putting anything in the vagina.
Anything in vagina. So don't check her cervix. And she also, if she has a known previa, she shouldn't be having intercourse either. A nurse is admitting a client at 42 weeks for induction of labor. What is a predictor of that the induction will be successful? Good job. So let's talk about the Bishop score. All right, how do we, what's the Bishop score for?
It kind of helps you decide which method of induction to use.
Mm-hmm. And how does it do that? What are we assessing to determine a Bishop score?
It's the
Is this one where it's how dilated you are and how soft your cervix is, or no?
Mm-hmm. Yep. And Shelby, what else were you going to say?
That was it, was the softening of the cervix and how dilated you were.
Yeah. So it looks at the how dilated, how effaced, the position, how soft it is, and the baby's position in the pelvis, like how high, what station. And all of these combine to create a number. This number is a 10, so 10 is good, right? What if her score was low? What if she had like a 3 or a 4?
Then, like, is she going to be on the fence whether or not like an induction would work or whether she would need an emergency C-section? Like, they just wouldn't know at that point.
Well, so I mean, that might be a consideration. Let's think about our client. So she's 42 weeks. So why are we inducing her?
She's
She is
post-term.
very long.
Yeah, she's because she's 42 weeks. She's post-term. And so we do need to deliver her, but we're not urgently delivering her, right? She doesn't have a medical condition like preeclampsia that makes us think we got to hurry and get this baby out. We just need to, it's time. So if her Bishop score is high, then that's a good predictor that our induction will be successful. If our Bishop score is low, one of you said that that can give us, the Bishop score gives us an kind of an indication of how to proceed, right? And so what if her score is low, what might we want to try to do to help improve her Bishop score?
Use like a peanut ball and stuff like that to maybe help
Conservative.
get her score high.
So Brooke, talk a little bit more about what you just said. Hold on, Maddie, for a
Use the
second. And
Cervidil to kind of help soften her cervix since it's not doing it on its own.
what is Cervidil? What's its purpose?
It helps soften the cervix, right?
Yep, good. So it's a prostaglandin. So Cervidil, also misoprostol or Cytotec. We talked about that medication in higher doses to help the uterus contract with hemorrhage. In tiny doses, it acts as a prostaglandin to soften the cervix. So if our Bishop score is low, we want to start with cervical ripening to soften the cervix and make it and raise the Bishop score to make it because it'll be more, what am I trying to say? It's going to open better if we soften it than if it's like trying to push on a closed door. If we've got this firm, hard cervix and we give her oxytocin and make her contract, and just like pounding on this firm cervix, nothing's happening. But prostaglandins, if the Bishop score is low, that's going to kind of help us decide what we're going to do to start her induction. She needs to be induced. She's 42 weeks. But how we do it is going to depend on our Bishop score.
Is Cervidil kind of one of the least invasive things you can do to help start labor naturally, not naturally, without like, just putting her on something that's going to make her contract like crazy?
This is going to progress to the next question, so I'll answer you in 1 second.
Okay.
Chronic hypertension is defined as hypertension prior to when? Sorry about that, Brooke.
It's okay.
So chronic hypertension is if she had hypertension before 20 weeks. If she doesn't develop hypertension until after 20 weeks, it's considered gestational. All right. In answer to the question about Cervidil, Cervidil is going to be, it's like a little flat disc that looks kind of like a flattened tampon, and it has the prostaglandins in it, and then it has a string. So it's put into the vagina and kind of back into what we call the posterior fornix, which is kind of behind the cervix. It can be really uncomfortable, and the medication in it can cause some vaginal irritation, but it's not super invasive. Um, Misoprostol or Cytotec low dose can be placed in the vagina. It also can be taken PO. And so I feel like that's probably the least invasive way to do it. As far as Pitocin, we give her Pitocin. It's going to make her contract. That runs through her IV. Until we have a cervix that is ready for labor, doing Pitocin or oxytocin can really be a long track because it's going to take a while for that to soften the cervix. Maddie, you have a question?
Just to make sure I heard you right, you said that it's defined as hypertension prior to 20 weeks, where it's just gestational hypertension?
Over 20 weeks is gestational.
Over.
If she didn't ever have hypertension ever, and now she's over 20 weeks and now she has high blood pressure, and we have those two readings more than 4 hours apart, she has developed gestational hypertension. If
Yeah, that's what
she
I was double checking.
has, yeah, if she has high blood pressure prior to that, prior to the 20 weeks, she probably had hypertension before she even got pregnant. She just might not have known. And that's chronic hypertension. Okay. Kind of talking about two things at the same time. So to answer everybody's questions, the nurse should recognize the emergence of the fetal head followed by retraction against the perineum is called what? So this is turtle sign if the head comes out and retracts against the perineum. For those of you that picked McRoberts, that is the first maneuver to use. Okay, what's McRoberts?
When you're bringing their legs like to their shoulders to help open up the pelvis.
Okay, good. So we lower the head of the bed and we are kind of pushing their knees towards their ears. All right. Sometimes McRoberts gets confused with knee chest, which is a different position we use for cord prolapse. And with knee chest, the knees are on the bed and the chest is on the bed and the butt is in the air. Okay, so but it sounds like similar because if with McRoberts we're putting her knees on her chest, kind of. So it gets a little confusing. But McRoberts, we're going to want to shift the pelvis, and so we want the legs to go this way. And then, but when the head retracts against the perineum, it's called a turtle sign. And if we see the turtle sign, we are going to start preparing for maneuvers and also call for help. I would pull my call light, set off the emergency light, and then put her in McRoberts position.
I just remember turtle and frogs are reptiles, so I think of the Roberts maneuver as like a frog position.
Oh, see, that's smart. You know, all students have different ways of remembering things, and sometimes I hear stuff like that, and I'm like, oh, that's a good one, and I use it again. Obese client with pregestational diabetes has a fetus that is macrosomic per ultrasound. The nurse is aware that what? Okay, so she's at increased risk of shoulder dystocia. So if she had pregestational diabetes and her baby's macrosomic now, how might they deliver her?
So C-section?
Yeah, she might be a C-section. What is the primary goal of treating gestational diabetes? Okay, let's talk about why red is not the answer to this. Okay, it is true that your patient who is diabetic and has poor glycemic control has an increased risk of spontaneous abortion and congenital malformations if they were diabetic before they got pregnant. Okay, If they have poor glycemic control at the very beginning of their pregnancy, that's when we can see those things happening. Why is it that the gestational diabetic does not have those risks?
Because they developed it after 20 weeks.
Yep. They were not pregnant, or I mean, they were not diabetic at the beginning of pregnancy when those things are a concern. Remember that congenital malformations are going to be in the embryonic period, okay, which is up until how many weeks?
12?
Week 8.
12.
8.
Through week 8. Yep, the fetal period starts in week 9. And she wasn't diabetic. Your gestational diabetic wasn't diabetic then. Okay, so that's why this answer is not red, is because it's talking about gestational diabetes. Now, if she was a pre-gestational diabetic, then all of these answers would be true. But for gestational diabetic, we just are concerned at this point of these choices, we're concerned about the fetal macrosomia. All right.
Miss McBride, my laptop died, and so it kicked me out. Are you able to add me back from here or no? It says
Can
I'm waiting on
you,
the on you.
I don't have, you mean to get back into Zoom?
No, the game.
You should let you add yourself in. There's not anything I have to click on my side.
Oh yeah, it just
Maybe
says
as
wait
it,
in the lobby.
okay, maybe as it progresses, because I had it paused. See, is it
Oh
letting you in
yeah,
now?
yeah.
Okay. 38-week G2P1 patient has a blood pressure of 172 over 114. She has proteinuria, headache, and difficulty focusing. What complication would the nurse work to prevent? Okay, the goal for her is to prevent the seizure, right? What medicine do we use to prevent seizures for this patient?
Magnesium sulfate.
Magnesium sulfate. So eclampsia is going to be if she's having the seizure. Preeclampsia is everything that leads up to it. Right now, she's preeclamptic. Okay. One person selected preterm labor. Why is preterm labor not? Well, first of all, she's 38 weeks. So is she preterm?
No.
No. Okay. Um, But all of these other signs, protein in the urine, headache, difficulty focusing, or blurry vision, all of these are signs of preeclampsia. And then this is also severe because look at her blood pressure is greater than 160 over 110. So we really need to prevent her from having a seizure, and we're going to give her magnesium sulfate. A client has an incompetent cervix at 20 weeks gestation. Which intervention will be ordered to prevent preterm birth? Okay, so let's talk about this one for a second. All right, we want to prevent preterm birth. Betamethasone, what does betamethasone do?
That mature the fetal lungs.
So it's not going to prevent preterm birth. Okay, so now we need to look at our other choices here. So what is an incompetent cervix?
It's when it's not staying closed. It's just kind of trying to open preterm.
Yeah. So there's a couple of things for this, guys. So the other thing that we call an incompetent cervix is cervical insufficiency. It's not staying closed. Okay. If I know that she has had second trimester losses before, then they might already be giving her something to help maintain her pregnancy. Does anybody know what hormone helps maintain the pregnancy?
Estrogen.
Estrogen. Okay. So estrogen is going to be the hormone that helps maintain the pregnancy. Does anybody know what hormone helps maintain the pregnancy? Estrogen. Okay. So estrogen is going to be the hormone that helps maintain the pregnancy.
The progesterone?
Progesterone. So patients who have had second trimester losses before, they might be giving progesterone to help maintain the pregnancy. For this patient right here, if she doesn't have a known history, she might not be on progesterone. If they're noticing that the cervix is opening and thinning too soon, they can do the cerclage. Does anybody know what a cerclage does?
It stitches the cervix shut to help support it so it stays intact.
Yeah, you stitch it closed to maintain the pregnancy. So to prevent preterm birth for her, they could place a cerclage. She's 20 weeks. This baby can't survive. And so the best way to try to keep her from delivering with an incompetent cervix or cervical insufficiency would be a cerclage. Tocolytic therapy. What is tocolytics?
On a blank.
Tocolytics are medications that decrease contractions. And if she was preterm, like 32 weeks, we wouldn't place a cerclage. We would consider tocolytic therapy and betamethasone for her baby in case it was born early. But for this patient at 20 weeks, tocolytic therapy is not going to be the thing that helps us.
I have
Okay.
a question about this cerclage.
Yeah.
So I had an incompetent cervix with a pregnancy, and then I got pregnant with twins after, and they were going to do a cerclage and sent me to MUSC, but then they said it's contraindicated for multiples. Do you see that being pretty common, or was it just because of where I was?
I'm trying to think if I've seen. So the hospital I work at now is not super high risk. It's possible at like a high risk facility, they do a lot more cerclages. I don't think I've seen cerclage on a patient with multiples, but I don't feel like I'm a good person to have. I don't have the kind of high risk experience in that kind of setting to really be able to answer that adequately. I could look up the
Gotcha.
data, but I don't know for sure.
It's
I
fine.
haven't
I was
seen
just
it.
wondering.
I haven't seen it, but that doesn't mean that it's not, that it's contraindicated or that it just hasn't been something I've seen in my own experience. I don't know.
Okay.
Tocolytic therapy is going to be medicines that slow contractions down. This is indomethacin, nifedipine, magnesium sulfate, and terbutaline. Those are our four tocolytics that relax the uterus. And then we have four medicines that we learned about for postpartum hemorrhage that help the uterus squeeze. Pitocin, Cytotec, Hemabate, and Methergid. Okay. Cytotec is misoprostol, is the other name. A nurse is administering prescribed medications prior to a cesarean delivery. Which should the nurse administer? Okay. Anybody who's having a C-section is going to get a prophylactic antibiotic. Okay. Because we're opening the uterus. And then we also give antacids so that because she's laying on her back with just a tilt, and if she vomits, we don't want her to aspirate acidic stomach content. Question, Maddie?
Can you repeat the four meds that slow down contractions? I got max sulfate, indomethacin, and then there was two more that you said.
Yep. So there's a little acronym that goes with this called "It's Not My Time." Indomethacin, nifedipine, magnesium sulfate, terbutaline.
I seen that in your announcements. I don't know why I asked that. Sorry.
You sure did, but that's okay. Ask it, take notes. It's fine. That's why we're here. Okay. All right. A nurse is reviewing the fetal matter tracing for a client with ruptured membranes. Which finding might indicate a cord prolapse? All right, why did we pick yellow?
Went based off of veil chop line right there.
Mm-hmm.
Variable disseminations said it to me.
Yeah, because if we have a cord prolapse, what's happening?
Or the cord compression.
We're getting cord compression. The cord has slipped down in front of the presenting part. And so we're getting pressure on the cord. So we can see variable decelerations. We can also see a bradycardia. It just depends, it depends on how much pressure is happening on the cord and if the pressure is relieving it all between contractions. So variable decelerations are going to be your cord compression. So you guys were all thinking right along the right path. So what should I do? So last week, 100%, this patient's tracing was like 120, and then it went down to like 190, boom, variable, boom, variable. And so fingers in the vagina feels the pulsing of a cord. What should we do?
Move the baby's head off the cord.
Okay. The finder should be the holder. So if you put your fingers in the vagina because you're seeing this pattern and you feel the pulsing of a cord, you should keep your hand in there and put pressure on the presenting part. Hopefully it's a head, to help relieve the pressure from the head on the cord. What positions might also help relieve pressure on the cord?
Knees to
To the
chest.
left side.
We can go on the extreme left, okay, where and if you go extreme, it can help rock the baby back. What else?
The knees to chest
Somebody
position.
So this is knees chest, where the knees are on the bed, the chest is in the bed, the butt's in the air, so that gravity rocks that baby back. And then there's one other position we can try for the same effect. It's Trendelenburg, where you lower the head of the bed. Okay, so I would say that oftentimes on exams and quizzes and HESI, we see knee chest. Oftentimes in practice, I see Trendelenburg. Anything that's going to let gravity pull that baby out of the pelvis a little bit is going to help, because the holder, it's hard to hold that kind of pressure with two fingers. Okay, so what kind of delivery for this patient?
C-section.
C-section, emergent. Okay, because for however much pressure is happening on the cord, we're not getting good oxygenated blood flow to our baby, and so we're asking our baby to hold their breath, right? So we're going to need to, priority is going to be oxygenation for our baby. So we're going to hold the presenting part off the cord, and we're going to put the patient in a position that lets gravity take that baby off the cord. So knee chest, Trendelenburg, probably knee chest. And we're going to go for emergency C-section. There's other things in your book that talks about like wrapping the cord in sterile saline soaked gauze and some of, I don't remember what else. If this happened outside of the hospital, those are things that you could talk about. Right now, we're in the hospital and the OR is right down the hall. I'm keeping the baby off the cord as much as I can, and I'm getting her back in the OR to deliver. Okay. EPROM client is receiving magnesium sulfate for neuroprotection. The nurse should monitor for which adverse effect? So PPROM is preterm premature rupture of membranes. So she's preterm. Yep, we're looking for those signs of toxicity. So we talked about this with this question earlier about magnesium sulfate, and I said, who gets magnesium sulfate? Your preeclamptic patient gets magnesium sulfate, and then sometimes your preterm patient does as well for neuroprotection for her baby. So we're monitoring for all of those same signs of magnesium toxicity for her. Which medication should the nurse expect to administer to a client who's experiencing preterm labor? Nifedipine, good. All of these other ones are tocolytics that are going to make the uterus contract, which it helps us for bleeding. Nifedipine is a tocolytic, which helps the uterus relax. We also gave nifedipine to a different patient that wasn't a preterm labor patient last week. Do you guys remember what we used nifedipine for in week 5? Anybody know? The other name for it is procardia. So nifedipine, we used it for our hypertensive patient. So our preeclamptic patient that comes in with those super high blood pressures, our first drug of choice is labetalol, but we give oh my gosh, we give the labetalol IV, and until we have IV access, we can give PO nifedipine because nifedipine is a calcium channel blocker that's going to help with the blood pressure. But because it works on calcium, it also affects the contractility of the uterus. So we can also use it as a tocolytic. But if it is a calcium channel blocker, what kind of assessment would I like to have on my patient before I give it to my patient to help decrease preterm labor contractions? What do you think?
Blood pressure.
Blood pressure. Good. Yep. A client's diagnosed with preeclampsia, what finding could indicate the client may be developing HELLP syndrome? Okay, so we started to talk about HELLP syndrome a little bit earlier. HELLP syndrome is a variation of preeclampsia, so we can still have hypertension, but we're going to see more liver involvement. We're going to see more thrombocytopenia because HELP stands for what? Does anybody know?
Let me say it. It's hemolysis, elevated liver function. I can't think of the rest of it.
And low platelets.
Low platelets. There we go.
So we're going to see worsening liver function tests. We're going to see lower platelets. So in preeclampsia, you can see elevated AST and ALT, and you can see thrombocytopenia, but with HELLP syndrome, it's much worse. All right. And so with HELLP syndrome, we're going to probably see epigastric pain or right upper quadrant pain because it's the liver. That's where the liver lives, is over here in the right upper quadrant that's being affected. And then the thrombocytopenia can be really significant. And so I've actually seen situations where with HELLP syndrome, we have to do emergency C-sections because the platelets are dropping so fast. We had one that the platelets on admission were 53,000, which is well below our threshold where we kind of want them above 100. and an hour and a half later they were 42. And so it's very dangerous. It can be very dangerous. But we're also going to still treat her with magnesium sulfate because she's still at risk of seizures as well. Uterine fundus right after delivery of the placenta is palpable where? Should be pretty close to the belly button right after birth. Okay. How much does it go down per day for normal involution? About 1 centimeter per day or 1 finger width per day. Oh, shucks, the game is stuck. All right, hold on. Nurse observes a client's amniotic fluid, decides that it appears to contain meconium because what kind of fluid would we see if it's meconium stained?
Green.
Green. So green is an indication of meconium staining in the fluid. What's the concern if we have meconium stained fluid?
Would we be worried if the baby's breathed it in?
Yeah, good. The
Respiratory.
baby's at risk of respiratory distress because if the meconium is in the lungs, then it can cause respiratory distress for the baby. This one's harder because you guys can't see the answers now. Delivered client has a temp of 101.4. The uterus is tender, unusually large, and not descending. What should the nurse assess next? So she's delivered. Fever, tender uterus.
What if we
That
want to
the
assess?
Say it again. What do you think? What do you think's happening if she's a delivered patient with a fever of 101.4 and a tender uterus?
choreo
Right.
So if she has a fever and a tender uterus and she's pregnant, then it's chorioamnionitis. If she has a fever and a tender uterus and she's postpartum, what's probably infected?
Would it be a hemorrhage?
It could cause a hemorrhage. So the thing that's probably infected for her would be endometritis or the endometrium or the lining of the uterus. And so oftentimes with that, then I want to know, so Shelby said, would it be a hemorrhage? I want to know what her bleeding looks like because when we have endometritis, it can cause a late postpartum hemorrhage. It can cause what we call subinvolution, where the uterus is not contracting down and returning to its pre-pregnant state. And this is what we see here. The uterus is tender, unusually large, and not descending. So I want to see what her bleeding looks like. Okay, I also want to know what it smells like because if there's an odor, that supports the diagnosis of endometritis or the infection. But there's two things to consider here. Number one is the endometritis, and number two is subinvolution and whether or not we're having bleeding. If I check her lochia and she's having subinvolution, what kind of lochia would I expect her to have if she's like a week out? Does anybody know?
Like typically or in this situation?
Typically. First, typically, if she was a week out from her delivery, what kind of lochia should she have?
Is it serosa? Is that right?
Yeah, it should be serosa. What does serosa look like?
Like a pinkish red? Pinkish?
Yeah, it's like pinkish and mucusy. And that's usually from about 3 days until about 10 days after delivery. So for this patient, if I check her lochia, I'm expecting to see serosa at 7 days. If I have red, if I have rubra, that's also a sign of subinvolution. So there's a lot of reasons to assess lochia on her, to see what color it is, to see if it has an odor, to see the volume, how much is coming out. Question, Maddie?
I'm so sorry to interrupt. I have class in 10 minutes, so I'm about to go get
Okay,
ready for that. Are you going to send
go.
this out so I can review the rest on my own later?
I'm going to send the recording.
Thank you so much. Have a good day.
I didn't expect this to take so long, but we're having great discussions. I don't want to rush you guys. All right, but
Yeah,
I'll send the recording
thank
out.
you.
Okay? All right. Okay, next question. Which of the following amounts of blood loss following um, birth marks the criteria of describing postpartum hemorrhage? So how much is too much?
2 pads in 2 hours or more?
Okay, yeah, if she's saturating a pad an hour, that's too much. How much volume-wise in mLs?
Oh,
More than 500 mLs for vaginal birth. More than 1,000 if it's a C-section. After precipitous delivery, a patient has continuous bright red trickling with a firm fundus and tachycardia. What condition could be the cause? What happens with a precipitous birth?
it's really quick.
It's really quick. And so if she's got, in this scenario, she's got a firm uterus, she's got constant trickling from the vagina, and she has tachycardia. And what is tachycardia signifying?
Oh, blood loss is hemorrhage.
Right. So we've got this constant trickling from she's got tachycardia in this, and so we go to massage her fundus. The fundus is, because the first thing I always see if there's bleeding is uterine atony. I think uterine atony, because it's usually what it is. This patient, though, had this precipitous delivery, which can cause her to have the baby came out so fast. Her uterus could be boggy, but she could also have lacerations, hematomas, who knows, right? And so now I know she's tachycardic, so I massaged her fundus first and it was firm, but I'm seeing this bright red trickle coming from her vagina. Where do you think the blood's coming from? Probably a laceration. Okay, that baby came down and out fast. There's probably a laceration that they missed. So if you have signs of hemorrhage, and tachycardia is our first vital sign change, right? If she's tachycardic, assess the fundus first. Massage it. If it's firm, it's probably a laceration if I see bleeding. If the fundus is firm and she's tachycardic and I don't see bleeding, maybe it's a hematoma, right? Because where's the blood going with a hematoma? Anybody know? With a hematoma, the blood's collecting in the tissue. So it's usually like in the vulva or in the vagina. And so your precipitous delivery has a higher prevalence of lacerations and hematomas. So if I see signs of hemorrhage, if I see tachycardia, I'm going to check the fundus. If the fundus is firm, I'm going to look at the pad. If the pad has blood on it, it's probably a laceration. If the pad isn't saturated, I'm going to look for hematoma. Make sense?
Yes.
Assessment for what complication has the highest priority for a client with severe postpartum hemorrhage?
precipitous delivery.
Okay. So this one is going to be hard to get without seeing the answers.
Yeah.
If she has a severe postpartum hemorrhage, she has a high risk of developing DIC, which is that consumptive coagulopathy where all the blood clotting factors are being used up for little microclots that are doing nothing, and now everything's bleeding. So you could see bleeding everywhere, puncture sites, in the urine, where the cuff is squeezing. She could have petechiae because it's breaking the little capillaries up, lots of different things. Okay. Normal involution 14 days postpartum. Where should I find the uterus 14 days after delivery, do you think?
Below the umbilicus, like closer to the pubis.
Yeah, I probably won't even be able to palpate it anymore because remember it goes down about a finger width per day or a centimeter. So by 14 days with a normal involution, I shouldn't be able to palpate it. If I can, then we're wondering why. Fetal heart rate is checked following the bag of water's rupture. So water breaks and we're going to check the heart rate because why?
Checking for distress
We're looking for
or
variables,
pressure.
right? Because when the water breaks, that is a classic time that as the water rushes out, it can pull the cord with it. And so we're looking to see if we see signs of cord compression, see if we see variable decelerations after the water breaks.
This is hard
And if we
without answer
do,
choices.
I know, but you got to think a minute. I'm not making you think long. I don't know why the game froze up. But that happened to me last time too. I might have to just build my games in Kahoot. New mom has saturated 2 pads in 30 minutes and has a boggy uterus. What should we do first?
Massage the fundus.
Massage the fundus. Yep. What else after massaging the fundus?
Would you call the provider?
Sure, because we probably need to give tocolytics. There's 3 things we should really do like right away. Massage first. Also, next would be manage the bladder. Okay, if the bladder's
That's right.
full, it's going to affect the contractility of the uterus. So I would, if she's saturating, if she's bleeding like this, I'm not getting her out of bed. I probably would put a catheter in, put in a Foley. And then medication would be next, which I need orders for. Usually there's a standing order though for Pitocin, so I'll hang a bag of Pitocin right away and call a provider for more orders. Maybe have them come assess.
And
We
one of the
also could be weighing the pads. Go ahead.
I was gonna say one of the indications that she needs to empty her bladder would be like the tilted fundus, right? Like if it's on one side.
Yep, if it's not midline, that's a good sign that she has a full bladder because it causes it to deviate, usually to the right. Also, it kind of raises it up. So usually like if I expect it at the belly button, and it's like 3 above and deviated to the right, that's a huge sign of a full bladder. So if I went in and I just was assessing her fundus and I found it was up and to the right, I might have her void if she's not bleeding. But for this patient who's bleeding, I probably put in a Foley. So it depends a little bit on safety. 37 weeks admitted with vaginal bleeding following the use of cocaine. What do you think could be the probable cause of her bleeding? Any idea?
I feel like I just heard this on another review this morning and I can't pull it out of my brain.
Okay, so cocaine is notorious for causing the placenta to separate. placental abruption. And so if she's using cocaine and now she comes in with vaginal bleeding, that's what I'm worried about is a placental abruption. What might I see or assess for her besides her bleeding?
Or pain.
Pain.
Um, I'm drawing a blank.
Okay, so remember that placental abruption's painful, right? It also, if you palpate her belly, because the uterus gets really irritated by the blood that's in there, and so we can see like little irritable contractions on the monitor. We can palpate a firm, rigid abdomen. And also we could probably see late decelerations with our baby because a lot of the blood that should be going through the placenta for the baby now isn't. It depends on the severity of the abruption, how affected the baby is by it. Okay. But all of those would be concerning. A nurse in labor and delivery is providing care for a client who's in preterm labor at 32 weeks gestation. Which of the following medications should the nurse anticipate the provider will prescribe to hasten lung maturity? Do you remember what this was? We talked about this already a little bit. We're going to talk about it more with our newborn. Actually, this week with preterm labor.
It's the beta methylzone injection.
Good. Betamethasone. Okay. Indomethacin is going to be something we can give as a tocolytic. Nifedipine is something we can give as a tocolytic. Calcium gluconate is the antidote for magnesium toxicity. Betamethasone is the medicine that we give to the mom as an injection, and it helps the baby produce more surfactant for their lungs. And so we do one dose, and then 24 hours later, we do a second dose. That's when giving a preterm labor patient magnesium sulfate can also help slow that down so we have time to get betamethasone on board. A nurse is educating a diabetic client to do daily kick counts. What's the benefit of teaching this? So remember we talked about this earlier when we were talking about diabetes and how this can be a sign of fetal well-being. You just have the mom do it every day and we know the baby's doing okay. A wiggly baby is a happy baby. Nurses caring for 4 3-day postpartum clients. Which client assessment requires the need for follow-up? So here are the answers. Why is yellow the best choice?
Because
You're worried about infection.
it's 3 days later. It should be the sarcosa. It should be pink and definitely no foul odor.
So the serosa it might still be rubra today because rubra can be 1 to 3 days and she is 3 days. So that by itself, I'm like, that's a little like we're right on that bubble, but I'm not necessarily worried about the rubra, but the fact that we have the odor is really a concern for infection. So then what else would I assess if she's got a foul smelling odor? Temperature. What else? What infection might this be if she has an odor in her lochia?
Subinvolution.
Well, it's an infection that can also cause subinvolution, but subinvolution is not an infection. That's just the uterus's inability to return to its pre-pregnant state. I put two concepts together when we talked about it. I don't want it to be confusing.
Would it be like the placental fragments left behind or something?
Not quite.
No? Okay.
So the infection that we're worried about that can cause the foul-smelling odor in the lochia is endometritis, or and it's infecting the endometrium at the place where the placenta was attached. Okay, that can cause subinvolution because the uterus can't contract and return to its pre-pregnant state because it's full of infection. Okay, but subinvolution is kind of its own thing. Subinvolution is not an infection. It's just the uterus's inability to return to its pre-pregnant state.
Got it.
But
I had this
the
backward.
endometritis can cause that. What was that, Brooke?
I said I had them backwards for some reason.
Well, I might, because I talked about them both together on that other question, and so I might have caused some confusion, so I apologize. 22 hours after delivery, the fundus is 3 centimeters above the umbilicus and to the right. What can bladder distension cause? Bleeding. Okay, so we talked about this with the other question, that the bladder's full. That's one of the things that we want to manage the bladder if she's bleeding.
The uterus.
Yep, the fundus of the uterus. If it's not midline and it's not where I found it before, close to the belly button, I'm thinking that the bladder's full. If the bladder's full and it's pushing on the uterus isn't going to contract well. It can cause uterine atony. So we can massage the uterus, but if the bladder's full, we also need to manage the bladder. So that's where we talked about either voiding or doing a Foley. For this patient, if I'm just assessing her and her uterus is deviated to the right and above the umbilicus, if she's not actively bleeding right now, I could have her void. But I know she's at risk of excessive uterine bleeding or postpartum hemorrhage because it can cause atony. So if she is actively bleeding like our last patient was, I would place a Foley. So just think about the bladder. Okay. Does that make sense?
Yes.
Pregnant client presents to the clinic with a complaint of a severe headache. What should we do first?
Take the blood pressure.
Take blood pressure. Good. Client is receiving magnesium sulfate for severe preeclampsia. What is our antidote for toxicity?
Calcium gluconate.
Calcium gluconate. Do you remember our signs of toxicity? Respiratory depression, decreased urine output, absent deep tendon reflexes. Those are the big ones. Did I say respiratory depression? That should be the first one I said. Also turn
Facial
it off. Okay. Also, decreased responsiveness. Also turn it off. So turn it off if you need to give calcium gluconate. Don't keep it on. The best response for a woman who tells the nurse, I feel tired and sick all the time since I had my baby 3 months ago. What do you think? Is that fine?
No. Describe what she means by sick.
Yeah, because we're worried about postpartum depression for her, right? And with postpartum depression, it's lasting longer than 2 weeks. The symptoms are worsening. So we really want more information here. Postpartum depression, they could be detaching from their newborn. They could be even having some thoughts of self-harm. It's not like psychosis though, right? Where psychosis, they have the erratic behaviors, hallucinations, delusions. I mean, I guess we don't know. She just said tired and sick. We need more information. Rh negative woman with a threatened abortion should receive RhoGAM, true or false? True. True. So with a threatened abortion, she's still pregnant. Okay, but she's having bleeding. We're going to try to keep her pregnant. But we need to give RhoGAM because we don't know if the baby is Rh positive. And this is a possibility where even though the blood should never mix, this is one of those situations where it's the possibility that the mom's blood could see the baby's blood and start building antibodies. So we would give RhoGAM to her. We want to try to keep her pregnant though. She hasn't lost the baby yet. So we might do bed rest for a while. We might, it depends on where we're at and how close we are to her being at an age of viability. Nurses caring for client with an ectopic pregnancy. What might we expect with an ectopic pregnancy?
Besides just like the signs and symptoms of a pregnancy, but ultrasound doesn't show that the baby is where it's supposed to be. It's in the fallopian tubes.
It's in the fallopian tube. So she could have vaginal bleeding. She had a positive pregnancy test. Okay, and she might present with pelvic pain and vaginal bleeding, and then the ultrasound shows that it's in the fallopian tube instead of in the uterus. This is concerning if the fallopian tube ruptures because she can hemorrhage into her belly. This is also a time she thought she was having a baby, so this can also be a very sorrowful time for her as well. If the vaginal delivery, the head delivers and the shoulders don't follow, we're going to do McRoberts. Remember we talked about this? So we're going to try to change the shape of the pelvis by pushing the knees up towards her ears. That's going to be the first thing to do. We don't do fundal pressure at all. Suprapubic pressure could be the next thing to do with pressure on the pubis to try to get the shoulder underneath. Immediate postpartum period signs and symptoms would indicate a patient is experiencing uterine atony. Foggy uterus. Okay, atony is the absence of tone. So that means it's not squeezing. And so instead of feeling firm, it feels squishy. All right. Also, maybe we're seeing a lot of bleeding. So all the things we talked about, like saturating the pad. Maybe we're seeing tachycardia, right? Which is our first vital sign change. What's the first medicine to use? We're going to massage the fundus, manage the bladder, and what's our first medication?
Would it be the oxytocin or Pitocin?
Yeah.
Oxytocin. Good. The nurse is caring for client receiving terbutaline to prevent preterm labor. What maternal assessment finding would be relevant to consider prior to administration?
If she's hypertensive.
Not for this one.
Oh, but I thought it was contraindicated with patients with hypertension.
Methergin is.
Got it.
Yep. Terbutaline causes tachycardia. And so if her heart rate was 132, I would say to the provider, her heart rate is 132. Do you still want me to give it? Because it's going to have the potential to increase her heart rate even more. It causes tachycardia as a side effect. A nurse is assessing dark red bloody discharge with scant to moderate flow. It doesn't specify, but this is postpartum. Okay. Lochia rubra. All right. So this lasts the first few days. It may increase when with standing and breastfeeding. So when she is like sitting down, it might pull in her vagina. She stands up, she might get a gush. Also, when she breastfeeds, what happens?
Those contractions.
Uterus contracts. Yeah, which can be really crampy for her. And that's normal, but it can also cause her to have some more gushes. And so that's also fine. Okay. These other ones, Lochia alba usually happens. So cirrhosis next, we talked about that, right? It's pink tinged. It lasts up to 2 weeks. It's usually done by about 10 days. So And then it switches to alba. And then alba is not a sign of subinvolution. That's not true. And it's also what they're assessing here. This flow can be scant sometimes, up to moderate flow sometimes, depending on her situation. That's not excessive bleeding. All right, questions for those that are still here?
Can you explain the low-key alba, like what it looks more like?
Alba happens usually by 2 weeks after delivery, but usually that transition usually happens around 10 days after birth. And so we go from rubra in the first few days, that's red and bloody. Then we go to serosa, which is that pink and mucusy. And then we switch to alba. Alba is a little bit yellowish or whitish, and it's kind of just can kind of it can last up to 6 weeks, but it's usually done sooner than that, and it's just kind of a whitish discharge. So this transition has to do with that the endometrium healing that section where the placenta was attached. And so alba, they might not even really notice it as much. It's just more like a yellowish whitish discharge. The things that I'm concerned about is if it's not following the normal progression or if it reverts back. If I have serosa that goes back to rubra, that can be a sign of subinvolution and late hemorrhage. But alba, usually by 2 weeks postpartum, we should be seeing alba, the whitish discharge.
Thank you.
Any other questions?